Hey everyone, and welcome to another video here at Whiteboard Doctor. Thanks for joining us today. Quick disclaimer before we move on. None of these videos are intended to be acted upon as medical advice. Please pause the video here and read the disclaimer in its entirety before moving on. Channel plug. Here at Whiteboard Doctor, our mission is to bring you interesting, relevant, and understandable medical education for all types of lifelong learners, trainees, and practitioners. If you want to follow along, we do have a lovely subscribe button in the bottom right-hand corner of all the videos. Don't forget to hit that like button. And lastly, if you'd like to support us outside of viewing our videos, we have several ways in which you can do that, linked in the video description and pinned comment. Stay well, keep learning, and back to the video. Alright, and welcome back to another video. This is going to be the third video in our acid-base disorder series. The first video was more of an introduction, definitions, terms, verbiage, talking about buffering systems, some of the introduction kind of physiology. The second video was introducing kind of metabolic and respiratory acidosis, alkalosis as primary disorders. Definitely check out both those videos. They're linked in this video's description for those that are kind of looking for a more comprehensive view, because this is a build-off from those. So there might be some terms and verbiage in this video that might not make sense if you aren't familiar with the content of those two videos. Today we're going to be diving into kind of the nitty-gritty of acidosis, alkalosis, metabolic, respiratory, compensated, uncompensated, acute versus chronic. It's going to be a video where we dive into a lot of the details, the numbers, the equations, while we keep kind of the general physiology in mind. So stick around while we go through all this. So to start, you would get an ABG, all right? The ABG gives us a view into the acid-base status of a person. So when you're evaluating for an acid-base disorder, you get an arterial blood gas. We actually did a video on arterial blood gases, again linked in the video description. And that arterial blood gas is a poke into the artery, and it gives us a glimpse into the acid-base status of a person, if you're worried that they're acidemic or alkalemic. In addition to that, the ABG, as we talked about in that other video, so it'll give us the pH like we mentioned. It'll also give us two other things we need though, and that is the PaCO2, which is the partial pressure of carbon dioxide in the arteries, and it'll give us the bicarb, all right, the bicarbonate. The bicarbonate is a calculated value, whereas the CO2 is a measured value, but they all can still be used. You could also get the bicarbonate off of a basic metabolic panel, which is a venous blood test. But when you want to know about acid-base disorders in a person, send that arterial blood gas. Depending on the results of that arterial blood gas, we can kind of walk through an algorithm. And if that arterial blood gas shows, a pH of less than 7.4 or less than 7.35 would be another number, or if it's greater than 7.4 or greater than 7.45, because the normal pH is generally considered 7.35 to 7.45, all right? So if the pH is less than that, 7.35, it is acidemic, an acidemia, and we talked about acidemia versus acidosis in that first video. If the pH is greater than 7.45, it's alkalemia. Acidemia is that the blood is too acidic. Alkalemia is the blood is too basic or alkalotic. How do you determine, though, if it's a metabolic versus a respiratory acidemia or alkalemia as the primary disorder? Well, there's a few ways you can look for that. If we start with acidemia, so we get our arterial blood gas and that pH is less than 7.4 or less than 7.35, so we know there's an acidemia. The next thing we're going to look at is the bicarb or the PaCO2. So we're going to look at the bicarbonate level or the PaCO2 level, the carbon dioxide level on that blood gas. If that bicarbonate is less than 24 milliequivalents, then you know that acidemia is a metabolic acidosis. In the previous videos, we've talked about why that might be, and it comes to this equation that we spent a lot of time on in those other videos, which is hydrogen and bicarb, which can go to H2CO3 carbonic acid, which can go to H2O, those are supposed to be two arrows, H2O plus CO2. So if our pH is less than 7.40 and our bicarbonate is low, bicarbonate is a base. So if the base is low, it's acidotic. So if that bicarbonate is low, you know that it's a metabolic acidosis. All right, and we're going to get into this next level about like kind of the compensatory stuff in a second, but we're going to stick above that green line for now. Whereas if instead the PaCO2 is greater than 40, that would be a respiratory acidosis. So anytime you have a pH less than 7.40, then look at your bicarbonate and your CO2 levels. If that bicarbonate is low, you know it's a metabolic acidosis. Whereas if that PCO2 is high, you know it's a respiratory acidosis, right? Because if this is increased in this portion of the equation, it shifts the equation this way and leads to an acidemia because it will produce more hydrogen ions. Whereas if the bicarbonate is low, you're going to have more hydrogen ions in that equation as well. So that is how you determine whether it's a primary. So this is going to be the primary disorder. That's a weird P, primary disorder in this tier. And that's how you determine if it's a primary metabolic acidosis versus respiratory acidosis. It depends on the bicarbonate level and the CO2 level. Now, if you get your arterial blood gas and that pH is greater than 7.45, that's an alkalemia. This means that the blood is too basic. And again, we'd go to our bicarbonate and our PaCO2 level. So opposite the acidemia, if our bicarbonate level is greater than 24, that's going to be a metabolic alkalosis, right? Because bicarbonate is a base. So if it is high, it means that the alkalosis is because of the bicarbonate, and that is a metabolic alkalosis as the primary disorder. If that PaCO2, though, is less than 40, that's going to be a respiratory alkalosis as the primary disorder. Now keep in mind you can have mixed. So if the bicarbonate is greater than 24 and the PaCO2 is less than 40, it would be a mixed metabolic plus respiratory alkalosis. That'd be the same thing over here. If the bicarb is less than 24 and the PaCO2 is greater than 40, it would be a mixed metabolic and a respiratory acidosis. All right, and that's how you can follow this chart to kind of determine the primary disorder. And again, if we go back to our equation over here, if that PaCO2 is less than 40, so if the PaCO2 is low, it means that the equation is going to go this way, so it's going to decrease the amount of hydrogen ions, and thus you're going to have less hydrogen ions and a more basic solution, or more alkalotic solution. And again, if that's confusing to you, that's what we've talked about in those first two videos, so definitely check those out. So now that we've talked about the primary, we wrote primary out over here. Here we'll do one with a degree sign, which stands for primary. So now that we know whether the primary disorder is acidemic, alkalemic, metabolic versus respiratory, then the question is, well, is there compensation? So there's two things that can compensate for an acidemia or alkalemia, and that is either respiratory or renal. Renal is metabolic, all right? And we covered this in the other videos, why that is. So the kidneys, right, if we draw a little bean here, the kidneys can either absorb more bicarbonate or excrete more hydrogen ions, and that's how they compensate renally for an acidosis or alkalosis. Whereas the lungs, right, the lungs can breathe out CO2 or hold on to CO2, and that's how the lungs, the respiratory, compensates for an acidosis or alkalosis. So if we go down this route and we have an acidemia, or pH is less than 7.4, 7.35, if the bicarb is less than 24, meaning it's a metabolic acidosis, then you look to the carbon dioxide. And if the carbon dioxide is less than 40, meaning, if we scroll up to this equation, meaning the carbon dioxide is low, so it is shifting the equation this way and decreasing the number of hydrogen ions, trying to make the blood have less hydrogen ions or be less acidotic, then the respiratory system is compensating. So if the PCO2, if the carbon dioxide level is low in a metabolic acidosis, that means that the lungs are compensating. And we're going to get into some specific numbers and equations in a second. Contrarily, if it's a respiratory acidosis, so our pH is less than 7.4, our pCO2 is greater than 40, so it's respiratory, meaning that CO2 is high, and the CO2 is driving the equation this way, meaning there's more hydrogen ions, and thus the solution is more acidemic. Then we look to the bicarb to see if there's a renal or metabolic compensation. If the bicarb is high, trying to increase the amount of base to balance out the respiratory acid, then you know that you've renally compensated, or the kidneys are trying to compensate. Now keep in mind the lungs, the respiratory compensation happens much faster than the kidneys or the metabolic compensation. So a respiratory compensation can happen in a matter of, minutes, whereas a renal or metabolic compensation takes more like hours to days before it can compensate. All right? Approach is similar for alkalemia. So if we have a metabolic alkalosis, pH is greater than 7.4, our bicarb is high. A bicarb is a base. Base is alkalotic. So if our bicarb, our base is high, that means it's a metabolic alkalosis. Then you look to the CO2. And remember, a high CO2 drives this equation to make more hydrogen ions, which means that it's trying to make the blood more acidic. So if the CO2 is high, it means it's trying to balance out this alkalosis, right, by increasing the amount of hydrogen ions. And that means that there's been a respiratory compensation. Contrarily, if it's a respiratory alkalosis, so our pH is greater than 7.40, our pCO2 is low, meaning there's less hydrogen ions, meaning it's alkalotic or basic from the respiratory system because the lungs control the CO2 concentrations. Then you look to the bicarb. If the bicarb is low, bicarb's a base, so low bicarb means there's less base, meaning it's a more acidic solution. Then there's a metabolic compensation happening. Okay, we're going to pause here and just give you a second to kind of digest that. So some of this stuff might be straightforward, right? pH less than 7.4, alkalemic greater than 7.4, acidemic greater than 7.4, alkalemic. In an acidosis, bicarb less than 24 means it's metabolic because bicarb's a base. Base is alkalotic, so less base means more acid. If the carbon dioxide is greater than 40, you know that higher carbon dioxides drive the equation this way, producing more hydrogen ions and more acid. That means it's a respiratory acidosis. And then it's kind of flip-flop whether it compensates, right? Because to compensate means you're trying to bring the blood pH back to a normal amount. So if the primary disorder is an acidosis, the appropriate compensation is trying to make the blood less acidic, or almost you could think of it like trying to induce an alkalosis to balance it out. So if we know that high CO2 is acidotic, low CO2 is alkalotic. So if there's a metabolic acidosis, having a lower CO2 means that those lungs are trying to make the blood more alkalotic, more basic, less acidotic. So there's an appropriate respiratory compensation. All right. Same thing, over here. If there's a metabolic alkalosis, meaning the blood is not acidic enough, the appropriate compensation is try to make the blood more acidic. So the respiratory system should be increasing the amount of CO2 because that will drive this equation to make more hydrogen ions, which makes the blood more acidic, and that's an appropriate respiratory compensation. This is in contrary to if the opposite was happening, where then you'd have a combined metabolic and respiratory acidosis or alkalosis. All right. So how do we know if it is the compensatory mechanism is happening appropriately, right? Because what should your CO2 be when you're compensating? Well, it depends on what your pH is and what your bicarbonate level is. And there's actually equations put forth to calculate this. Unfortunately, these are equations that would just need to be memorized. They're very common equations that come up on the wards. The first is Winter's formula. So Winter's formula is a equation you would use if there's a primary metabolic acidosis. Remember, that means the pH is less than 7.35, okay? And the bicarb, which is a base, which is alkalotic, is less than 24, meaning there's more acid. And this is a metabolic acidosis. What should happen in a metabolic acidosis is a respiratory compensation, meaning the respiratory system should be trying to make the blood less acidic or more basic. And to do that, right, you would need a decrease in your carbon dioxide level, a decrease in your PaCO2. But how much should that PaCO2 be decreased? Well, that is what this equation tells you. So the expected PaCO2, meaning if there were appropriate compensation from the lungs to compensate for the metabolic acidosis, this equation would drive what the CO2 should be. And that is 1.5 times the bicarbonate level plus 8, plus or minus 2 is just kind of a degree of error. So what that would look like is, here's an example. So your bicarbonate level is 14, your pH is 7.31, right? So this is less than 7.35, so it's acidemic. Your bicarb is less than 24, meaning it's a metabolic acidosis. So what should your lungs be doing for an appropriate respiratory compensation? Well, 1.5 times the bicarbonate level, right, which is 14, plus 8 plus or minus 2. So the PCO2, the carbon dioxide level in the blood off that ABG, should be somewhere between 27 and 31 if the lungs are doing the right thing to compensate. And as we said, a decreased PCO2, right, which is less than 40, would be a respiratory compensation. And if that PCO2 comes back on the arterial blood gases between 27 and 31, then what you have is a metabolic acidosis with appropriate respiratory compensation. All right? This results in about a decrease of 1.2 millimeters of mercury in the carbon dioxide level for every decrease of 1 in the bicarbonate level. So that's kind of a little kind of cheat if you didn't want to do the whole equation. So if you just the PCO2, the CO2 level should decrease by about 1.2 for every decrease of 1 in the bicarbonate level. So it'll give us a little different answer, but if we use that, normal bicarb, as we talked about, is 24. The bicarb in this equation was 14. So that means there's a decrease in what? A decrease in 10 milliequivalents of bicarb compared to normal. And what this cheat is saying is that the CO2 should decrease by 1.2 for every 1. So if we times this by 1.2, let's see if I could do math here quick. That's going to be what, 12-ish? About 12. So there should be a decrease in about 12 millimeters of mercury of CO2 if the lungs were to compensate appropriately. A normal CO2, NL normal CO2 is 40. So that minus 12 would give us what? 28, which gives us about what the equation gives us as well. So if you don't want to do the equation, you just want to memorize 1.2 for every 1, you could do that as well. So that's Winter's formula. That is strictly for a metabolic acidosis. Oh, you can't see that. We're going to erase that. All right. What about, though, if the primary disorder, instead of being a metabolic acidosis, is a metabolic alkalosis? So this is the primary one with a degree. That's primary disorder. This is the primary disorder. All right. Well, there's another equation to calculate whether the CO2 compensates for a metabolic alkalosis. Right. So metabolic alkalosis, pH of greater than 7.4, or you could say 7.45. That's a little sloppy. We're going to write that again. 7.45. And a bicarb level that's going to be high, right? Because it's a metabolic alkalosis. Bicarb is a base, so if you have a high bicarb, you have a metabolic alkalosis as your primary disorder. This is still super sloppy. All right, third time's a charm here. There we go. So if the primary disorder is a metabolic alkalosis, then what you would be looking for is, do you have appropriate respiratory compensation, right? And we know that high CO2s, so to compensate, you would expect the CO2 level to be trying to induce more acidosis, right? Because the primary disorder is alkalosis. So to compensate and try to bring that pH back to normal, you need to have the lungs be inducing an acidosis, because acidosis and alkalosis balance each other out to net neutral. And as we talked about, high CO2 increases the amount of hydrogen ions, which increases the acidity of the solution. So you expect the lungs to be holding on to CO2 and increasing the CO2 level, but how do we know that the lungs are doing a good enough job? And that is what this equation shows. So this is the expected PCO2, right? The carbon dioxide level that would be expected if the lungs were doing their job to compensate for the metabolic alkalosis. And the equation is going to be 40 plus 0.6 times the bicarb, all right? So if we just do, let's see, we can just make up a problem right now. So the pH is going to be 7.50. 7.50. The bicarb is going to be high, right? Because it's a metabolic alkalosis. 24 is normal, so we're going to say the bicarb is 32. So if we do this equation, 40, wow, we don't know why there's that lag with our writing, apologies, plus 0.6 times the bicarb, which is 32. And to be fair, this is not appropriately compensated because the pH is not about normal. So we're going to change the pH to show that it's compensated. So the pH is 7.45 with the high bicarb. 0.6 times 32. We've got our handy dandy phones here and get our calculator. Could have done this ahead of time, but we decided to do a problem on the spot. So 0.6 times 32 plus 40, you would expect the PCO2, the carbon dioxide level, to be 59 if the lungs were appropriately compensating. Remember, normal carbon dioxide is 40. So this is high. As we said, it should be high to compensate for metabolic alkalosis. All right, and then some throughout this cheat kind of shortcut way, we're just going to cross that out. It gives you a little bit different math. So when it comes to respiratory formulations, right, so these were primary metabolic. But if the primary disorder is respiratory, there's actually a nice little cheat box way in which you can remember the compensation, and that is this here. But we want to explain what it's laying out because it can be a little confusing. So for this, it's important to know whether it's acute versus chronic respiratory, right? This comes into play for respiratory, primary respiratory, because if you have something like COPD, right, chronic obstructive pulmonary disease, or emphysema is another kind of way to think about it, you are a chronic retainer of CO2. So if you are a chronic retainer of CO2, your CO2 levels are always a little bit high, and your kidneys compensate a little differently for those constantly high CO2 levels. There's other diseases that cause this too. It's not just COPD and emphysema, but if you are a chronic retainer, then this is going to be different. This would also be for someone who they might not be a chronic retainer, but they have a pathology that has been going on for a number of days or weeks that changes them to have kind of a different baseline level of CO2, a more chronic, rather than like an acute that just happened over hours change in their CO2 levels. So when we look at this, the left column is for a primary disorder of respiratory acidosis. The right column is for a primary disorder of respiratory alkalosis. Not sure if this is helpful for anyone else, but the way we remember this is that the first letter that differs between respiratory acidosis and alkalosis is this second letter. And C comes before L, thus C and acidosis is in the first column, and L and alkalosis is in the second column. Not sure if that's helpful for anyone else. Our brain's weird. Then what you have in the first column is the carbon dioxide level, which is C. And in the second column, you have the bicarb level, which is H. It's a little cheating because we're ignoring the P. Let's actually just erase the P. We don't even need it. So again, CO2 is in the first level, comes earlier in the alphabet. H is in the second column, comes earlier in the alphabet. I think we said level. So CO2, respiratory acidosis, first column, respiratory alkalosis, bicarb, second column. And then you have acute, first row. Acute comes first, chronic, second row. Chronic comes later. And what this is telling you is the change in the CO2, because CO2, right, is first, semicolon, compared to the change in the bicarb that you would expect for a compensated respiratory acidosis. So what does this actually look like? What they're saying is that for a respiratory acidosis, so you have respiratory acidosis that's compensated, so we're going to say the pH is 7.32, slightly low. It's respiratory, right? Respiratory acidosis, the PCO2 is high because high carbon dioxide drives that equation to the left, produces more hydrogen ions, so the PCO2 is high, greater than 40, so it's going to be 49. For every increase of 10 in the carbon dioxide, which means we're going to make this an even 50 for the E's, there's going to be an increase of 1 in the bicarb to compensate. So if you've increased your carbon dioxide to 10, that means your bicarb, a normal is 24, you're going to expect your bicarb to be 25 to compensate. All right. Similarly, that's acute, right? So if it's acute respiratory acidosis, where if you have a chronic respiratory acidosis, let's do the same thing. We're going to put a little a here because this is the bicarb that would be there for acute. If you have a chronic respiratory acidosis, for every increase of 10 in the carbon dioxide level, increase of 10 in the carbon dioxide level, semicolon bicarb, you'd have a semicolon increase of 3 in the bicarb. So you'd expect the bicarb to be 27 from 24 for a chronic respiratory acidosis with metabolic compensation. All right? So this is, increase in carbon dioxide level compared to increase in bicarb level. First column, respiratory acidosis. Second column, alkalosis. This is the same verbiage, but instead of increase, it's decrease. So for respiratory alkalosis that's compensated, we'll say for alkalosis, pH is, but it's going to be compensated, so it'll be let's say it's 7.44. So between 3.5 and 4.5, but a little higher than 4. It's a respiratory alkalosis, so our PCO2 is going to be low, right? Because low PCO2 shifts the equation to the right, consumes hydrogen ions, so there's less hydrogen and more acidosis. So our PCO2 is going to be low, less than 40. We'll say the PCO2 is 30 for the sake of ease of math. So for an acute respiratory alkalosis, the metabolic compensation, you would expect the bicarb for every 10 decrease in the CO2, the bicarb to decrease by 2. Normal bicarb is 24. So you expect the bicarb in a metabolically compensated acute respiratory alkalosis to be 22. Whereas if it was a chronic respiratory alkalosis, for every 10 decrease in the CO2, right, you'd expect a decrease of 4 in the bicarb instead of a decrease of 2 in the bicarb. So instead of 22, normal bicarb's 24, you'd expect the bicarb to be 20 for a chronic respiratory alkalosis with metabolic compensation. Does that make sense? Hopefully it does. The chart, once you get to know it, makes a lot of sense. And it's actually kind of nice, right? Because what it actually ends up looking like is over here. You have 1, 3, 2, 4, which is somewhat easy to remember because the constant here is the change in the PCO2. It's always either an increase in 10 for acidosis, which we know CO2 increases in acidosis, or a decrease in 10 for alkalosis. And then what the, we lost our microphone there for a second. And then what the bicarb does is either increases by 1, increases by 3, or decreases by 2, decreases by 4. So what you have is something easier to remember. You have 1, 3, 2, 4. Or 1, 2, 3, 4, whichever way you want to remember it, as long as you remember the parts of the chart, which this is respiratory acidosis versus respiratory alkalosis. We remember it because C comes before L in the alphabet. And then acute versus chronic. We remember it because acute is before chronic. And that's 1, 2, 3, 4, or 1, 3, 2, 4, whichever way you want to memorize it. All right, so this was a complex, long-ish video, but it's really important to memorize some of these equations. Honestly, we rarely use the metabolic alkalosis compensatory equation, but we frequently use this table as well as Winter's formula up here for metabolic acidosis. And obviously, before you can do that, you need to know what the bicarb and the carbon dioxide levels do in a metabolic versus respiratory acidemia versus alkalemia. So let us know what thoughts, comments, questions you have down below. We're happy to answer any questions that come up. Definitely, if this is confusing, check out our previous videos. And if you feel like you've mastered the previous videos and this one, then definitely move on to videos 4 and 5, getting towards the end of the comprehensive understanding of acid-base disorders. Otherwise, subscribe, hit the bell button, all that good stuff. We appreciate you all. Stay well, keep learning, and we will see you next time.